Hello, folks! Today I want to educate you briefly on some must-knows and must-dos for prevention of pressure injuries. But before we get to those, let's review the concept of pressure injuries. Pressure injuries are caused by friction, shearing, or when one point moves directly along another surface, often deep features relative to superficial ones, or direct pressure. Constant pressure from these sources causes ischemia, a loss of blood supply. With blood supply lessened or cut off, nutrition and waste management of the cells deteriorates and can lead to anoxia or necrosis, or lack of oxygen to cells and cell death, respectively. Let's visualize these must-knows. Friction is the rough, uncomfortable sensation of the chair that doesn't fit well enough, perhaps as arms rub against inappropriately high armrests during propelling motion. Shearing is the pull on the sacrum as a patient slides down in bed because their bed was placed with the head too high up. The deep feature of the sacrum conflicts with the skin against the gown in bed, moving away from each other as they slide down. Direct pressure is exactly that, pressure applied directly to your patient. However, while we intuitively understand the danger of high pressure on the body, low pressure over long times should not be underestimated. As little as 60 to 70 millimeters mercury of pressure over 1 to 2 hours can begin irreversible skin damage, depending on the location. That pressure is around the lower end of healthy diastolic blood pressure, as gentle as your heart beating. So note the location of wrinkles in clothes, IV lines, or other tubing, or items left in a patient's bed. I won't subject you to the pictures of stage 4 pressure injuries, mostly because I don't want to draw things that look that painful. But keep in mind that these are injuries that progress deeper and deeper and lead to worse and less reversible damage as they do. So how do we prevent them? Must know. Let's consider that even 1 hour of low, consistent pressure can begin permanent damage to sensitive parts of the body. Look at this body, our good friend Susie, and the highest points of pressure where she is positioned. We want to take the time to add support or eliminate pressure to the calcaneus, her sacrum, her olecranon processes, her scapulae, her cervical vertebra, especially C7, and her occipital protuberance while she lays in supine. This support should go to neighboring joints. Support under the knee and calf to float the calcaneus. Support under the elbows with pillows to float the olecranon processes off of direct pressure. For the sacrum, the occipital protuberance, cervical spine, and scapulae, we would reposition Susie. The points of greatest weight bearing in each position are likely points for pressure injuries. Repositioned to side lying, Susie now bears her weight between her medial malleoli and the lateral malleoli in contact with the bed, the medial epicondyles of her femurs and tibial head in contact with the bed, the greater trochanter of the femur in contact with the bed, and along with the lower arm, the wrist, the whole elbow, the greater tubercle of the humerus, and the acromion, and ultimately the side of the face on the bed. Again, pillows and support can reposition the affected points of the body to reduce pressure and improve the time spent in this position. Now, a must-do. You must always reposition patients who are completely dependent every 2 hours when they are laying down, and every 15 minutes if they are sitting. This is not all on you, but awareness can keep you aware of how to evaluate effective positioning. Think to yourself, would I want to be in that position for 2 hours without the ability to meaningfully change it? Would that wrinkle bother me? With empathy at the forefront, we can not only keep our patients comfortable, but treat them with kindness and consideration during a trying time.